Hi everybody and welcome to our module on lithium. Lithium is a chemical element. You can find it on the periodic table right above sodium. It's also a cation, which means it is positively charged. And lithium was the first medical therapy that was ever determined to be effective for bipolar disorder. This happened in 1949. It's still used for bipolar disorder in some cases today. Now, lithium has many toxicities and a narrow therapeutic index, so patients who take lithium must have their serum level monitored and their dose titrated. If their lithium level is low, it means they are subtherapeutic and not getting the benefit of the drug. If their lithium level is high, it means there's an increased risk of toxicity. Even though lithium's been used for a long time for bipolar disorder, the mechanism is still incompletely understood. One thing that people have figured out that lithium does is it inhibits an enzyme called inositol monophosphatase. This enzyme is used inside of cells to regenerate inositol, and it's hypothesized that this may have to do with this mechanism, although how this leads to benefits for bipolar patients is unclear. But what happens when patients take lithium is that they have depleted levels of inositol inside of their cells, and inositol is used for a number of second messenger systems, so those levels of second messengers fall. In some other videos, I talk about second messenger systems for G proteins and other signaling systems in cells. Some of these include molecules like PIP2, IP3, and DAG. All of these involve inositol, so when the level falls in a patient on lithium, that is hypothesized to be one of the potential mechanisms of the drug's benefit. If you can remember that lithium is on the periodic table right next to sodium, it's very easy to remember many of lithium's features. Just like sodium, lithium is primarily renally excreted, and just like sodium, it's mostly reabsorbed in the proximal tubule like sodium, however some goes out in the urine. And because of this mechanism of drug excretion, lithium is contraindicated in patients with significant renal impairment, although the drug can be used in patients with milder degrees of renal insufficiency. So risk factors for lithium toxicity all make sense if you just remember that lithium behaves like sodium and it's renally excreted. So patients who have some degree of renal insufficiency and take lithium are at higher risk for toxicity. Patients who become volume depleted will filter less plasma and they're at increased risk for toxicity. And in addition, elderly patients have a higher risk of lithium toxicity. That's because the glomerular filtration rate normally falls as we get older. Lithium has a number of drug interactions, and these are all very easy to remember if you just remember that lithium is renally excreted, because all of these groups of drugs affect the kidneys. So drug classes that increase the lithium level and raise the risk for toxicity include thiazide diuretics, NSAIDs, and ACE inhibitors. And you should know if you've watched the renal videos that all of these groups of drugs affect the kidneys. So thiazide diuretics can decrease the GFR, NSAIDs can decrease renal perfusion, and ACE inhibitors can decrease the GFR. So it makes sense that all of these will lead to less lithium going out in the urine and a higher lithium level. And I've bolded thiazide diuretics because this is a classic board question. It appears on the STEP exams, on the internal medicine exams, and even the emergency medicine exams. A patient on lithium who has started on a thiazide diuretic for hypertension is a classic patient to develop lithium toxicity, and that's because thiazide diuretics raise the lithium level. Now, potassium-sparing diuretics are a special class of drugs. They affect the kidneys, but what they do is they decrease the lithium level, and we'll talk about why this happens later. And then finally, loop diuretics can increase or decrease the level. They have varying effects, and this is because they lead to volume depletion, but they also cause more lithium to go out in the urine. For the remainder of this video, I'm going to talk about the adverse effects of lithium, and you can basically break these down into three groups. First are the acute effects, which occur right after a patient starts the drug. There's basically only one of these, and that's tremor. Long-term, patients who take lithium therapy are at risk for thyroid problems, kidney problems, and cardiac problems, and we'll talk about all of those. And then finally, mothers who take lithium during pregnancy place the baby at risk for fetal effects of the drug, and the classic one of these is Epstein's anomaly, and we'll talk about that as well. Tremor is a classic side effect of lithium therapy. It occurs when the drug is started or when the dose is increased. It's symmetric, and it's usually limited to the hands or arms. A classic complaint of a patient newly started on lithium is to say that both of their hands are trembling. This usually gets better over time, and it's the most common symptom of lithium toxicity, so always remember this. This is something they're likely to ask you about on your boards. Patients who take lithium for long periods of time are at risk for thyroid problems. Lithium is a goitrogen, and I discuss goitrogens in the endocrine section in the videos on thyroid abnormalities. Goitrogens are substances that inhibit the release of thyroid hormone from the thyroid gland. For this reason, the thyroid gland is stimulated to produce more hormone, and this commonly causes a goiter, which is an enlarged thyroid. 40 to 50% of patients taking lithium have an enlarged thyroid. And in some cases, the lithium suppresses thyroid hormone production to such a degree that the patient can develop hypothyroidism. Lithium is a classic cause of nephrogenic diabetes insipidus. You will read in your textbooks that lithium causes a chronic tubulointerstitial nephropathy, and what this means is that the tubules in the kidneys become unable to concentrate the urine and they do not respond to ADH. As a result, lots of free water goes out in the urine, and the urine is very dilute with a low urine osmolarity. Because there's lots of urine being produced, the patient will complain of polyuria, and the polyuria will make them thirsty, so they will drink a lot and complain of polydipsia, meaning they're thirsty all the time. Now, in some cases, the loss of free water will increase the serum sodium. However, in many cases, patients drink enough to keep up with the free water loss, and in these cases, the serum sodium can be normal. So remember that a normal serum sodium does not exclude diabetes insipidus. In terms of treatment of nephrogenic diabetes insipidus caused by lithium, if you administer vasopressin, which is an antidiuretic hormone analog, you will see no response. In other words, no change in the urine osmolarity, and that's because this is a form of nephrogenic DI, and only central diabetes insipidus responds to vasopressin. The ideal treatment is to discontinue the lithium, but this is not always possible. Some patients with bipolar disorder really need the drug. And in those cases, you can use a diuretic called amiloride. Amiloride is a potassium-sparing diuretic, and it inhibits sodium channels in principal cells in the collecting duct called ENaC channels. And when these channels are inhibited, lithium entry into kidney cells is blocked, so the drug is not able to cause toxicity. Shown on this slide is a drawing from our video on nephron physiology in the renal section. In that video, I talk about the principal cells of the collecting duct. Those cells have a sodium channel called the ENaC sodium channel, which reabsorbs sodium from the urine, in other words, from the lumen of the nephron, and it brings the sodium inside the principal cell. Well, it turns out that this channel also reabsorbs lithium, so it brings lithium into the principal cells, and once inside, the lithium can cause toxicity. So if you give a patient amiloride, you block this channel, and therefore there is less lithium inside the principal cells and less toxicity, and this can improve nephrogenic diabetes insipidus. This is also the reason that potassium-sparing diuretics like amiloride cause lithium levels to fall. They block the reabsorption of lithium, so more goes out in the urine, and the serum lithium level will become lower. Lithium can potentially have a number of effects on the heart. One of the common ones is that it can suppress the sinus node. Remember that when the sinus node depolarizes, that generates the P wave on the EKG. So if a patient is taking lithium, they may have sinus node dysfunction. This can lead to bradycardia, pauses, and in some cases it can lead to syncope. Finally, I'll discuss maternal lithium. If a woman is taking lithium therapy for bipolar disorder and she becomes pregnant, the baby is at risk because lithium is a teratogen. It completely equilibrates across the placenta. Remember, it's just like sodium, so the baby is exposed to the same level as the mother. And the teratogenic effects in the fetus primarily involve the heart. The classic teratogenic effect of lithium toxicity is Ebstein's anomaly. I talk about Ebstein's anomaly in the cardiology section. Ebstein's anomaly involves apical displacement of the tricuspid valve. That means the tricuspid valve, which is normally found in the right ventricle at about this level, is displaced down towards the apex, and this often leads to tricuspid regurgitation and right heart failure. And that's the classic fetal adverse effect of a mother who takes lithium during pregnancy. And that concludes our video on lithium.